So topic number 2 is pigtail catheters for urinary diversion. Again, I have these professional relationships, but these have got nothing whatsoever to do with urinary diversion. So the locking loop pigtail catheter is a relatively new invention in medical science and have been really transformative as far as our options for managing various conditions. And it all starts basically with a polymer, a plasticky polymer that has a memory coil. And so this little piece of plastic is designed and determined this is the shape that it wants to be. If you force it to go straight, it will temporarily be straight. But as soon as you let the plastic go, the polymer's memory is going to make it back into this little pigtail. So any catheter that has a memory, we call it a pigtail catheter. And then the locking loop ones are when they've actually got a little piece of string, like a little tiny piece of suture, that comes from the end of the catheter and then runs up and through the catheter. When that string is untethered, you can straighten out the catheter. When the string is pulled tight at the top of the device, that locking loop is now trapped. Now that loop is going to stay as a loop. It's much like harnessing a horse. You've pulled that horse's nose down, and it cannot now straighten up its head. So that's the idea behind the locking loop. These devices are biocompatible, so they're designed to sit in body cavities for long periods of time. And they usually are very nicely radio opaque. Some of them have very specific markers to make parts of them even more radio opaque. But you can see these catheters very, very easily with a standard radiograph. So there's lots of uses for locking loop pigtail catheters. Once you get a couple in your practice, you'll probably think, this is a good candidate for a locking loop pigtail catheter. In my practice, we use them for pleural drainage. We use them a lot for peritoneal drainage. We will absolutely use them for a nephrostomy tube. And then probably the commonest reason that we use them actually is as a temporary cystotomy tube. So we use them primarily for urinary diversion. But you can absolutely put locking loop catheters in other body parts. They can sit in the chest and they can sit in the abdominal cavity. So they all have basically the same standard components. So the very, very inner part is the puncture needle. So the very, very central part is a sharp puncture needle. It's got a cutting end on the tip. It's extremely thin. This sits inside the hollow trocar, or the inner stylet. So this sits inside the hollow trocar inner stylet. And then these two things together then sit inside the catheter. Depending on the size of the catheter, they have a very, very strong determination to make their pigtail. I mean, as soon as you get them out, they are going to pigtail themselves. That is their determination. And so often they're packaged with this straightening device because as you introduce, you put this into here, and then those two things together go down the catheter. You need to straighten out the end of the catheter in order to get your stylet and your needle to the end. And so we use the straightening device just to straighten the catheter out to let us go ahead and get those inner devices in. This is just a close-up again of the pigtail end. We've got the pigtail, and then we've got the string, and the string goes all the way up to the top, and that lets us lock that loop. One of the things you need to appreciate on a pigtail catheter, so I put this red line here, is that when you've placed it in whatever your body cavity is, you have to make sure that you've got all of the loop inside the body cavity. And this one just has one perforation, but many locking loop catheters have several perforations, and they'll sit all the way around on the loop. Generally, if you're just above the loop, you've got all of the perforations in the body cavity. So always have to make sure, get a sense of how much catheter has to be in so that I'm sure that all of my perforations are definitely inside the body cavity. Some of the locking loop catheters actually come with a really dramatic radio opaque marker, so you can see exactly where this is. Not all of them have this. The whole tube is always visible, but the extra black marker makes it even easier to see. If this is in your target zone, then you're 100% sure that your loop with the variable number of perforations is in your target body part. So they're an ideal way of diverting urine in a crisis. And so it's a very, very simple solution for the difficult urethral obstruction. So it's not unusual for us to get referred in blocked cats who've already been elsewhere and been unsuccessfully attempted to be unblocked. And so in my practice, because we're a tertiary referral, we sometimes get cats that are severely blocked, and it's now going to be very, very difficult to unblock them. I have to say, I am not an expert unblocker. And so if one of these patients arrives on my shift, my first instinct is I'm going to stabilize the patient and divert the urine, and then we can worry later about how to unblock the cat. And so these locking loop catheters are a great way of just getting you out of that panic about trying to unblock the patient. So very, very useful for patients who've got urethral tract inflammation, stones, a stricture, or a tumor. Also very useful for patients who've got a urethral tear, in which case you absolutely cannot pass a urethral catheter. You're not going to be able to find your way, and you simply divert the urine using a locking loop, and then you can calm down, stabilize the patient, and then make a definitive plan. So hopefully you can see this. So this actually was sadly taken at the teaching hospital. This was an intern's attempt to unblock the cat. Do we see a problem? Yeah. And so this is a patient where if I got this call and was shown this radiograph, I would think, interns, don't you love them? Okay, so maybe we just have to wait until the bladder's a bit more full. We'll put in a locking loop, and we'll worry about this later. This is another scenario. This is a patient who had a bad traumatic pelvic fracture. So I don't know where the urethra is sitting in this patient. I have absolutely no idea. This is a catheter going up this way. Contrast is going everywhere. It's had an intravenous study. You can see the pyelogram. You can see the ureters. You can see the bladder. And then it's chaos. I have absolutely no idea. And this is going to require some careful surgical planning. This is a great patient for putting in a locking loop catheter. We do usually sedate. If the patient is really moribund, it is so fast to get in the locking loop that sometimes I'll say, local, hold him still, we'll get it done. But usually we do sedate when we do this. If you are going to sedate, you've got to consider their global metabolic state as far as what drugs are you giving, how are they excreted, what is their GFR, kind of where are they sitting as far as renal function. The other thing to bear in mind is that we are putting this device into the bladder. So if the patient has substantial bladder disease, this may not be a wise choice. And so a bladder that is neoplastic, a bladder that is infarcted, a bladder that is severely damaged by, say, emphysematous cystitis, these may not be bladders that hold well. Having said that, if you put a locking loop pigtail in the bladder and then the bladder fails, and you've got a bladder rupture or leakage, heck, your pigtail is still in the peritoneal cavity and is now simply a peritoneal drain. So it still isn't the worst thing in the world. And if all you can do is put in a pigtail, recognizing the bladder may be less than perfect, you've still got a way to get the urine out of the patient. But if this was the ultrasound on a patient with a urethral obstruction, I'd look at this ultrasound and think, this is probably transitional cell carcinoma. There's probably TCC here. This whole bladder wall doesn't look very nice. This is not a patient I'd be thrilled about putting a locking loop in. I do risk seeding the TCC. But if I absolutely cannot unblock this animal, it is a realistic thing to attempt to do. So I'd rather not do it with a diseased bladder, but if I have no choice, I have no choice. We do it aseptically, and ultrasound guidance, I think, is really helpful. I mean, really, you don't always need it, but it's reassuring just to make 100% sure you know where you're going, 100% sure that you're nicely advanced in the bladder. But if you haven't got access to ultrasound, you can actually just do it blindly. Before you get rolling, you do need to open the device, put on your sterile gloves, and figure it all out. So pre-assembled device. So you've got your puncture needle, your trocar, your hollow trocar that's blunt. You've got your pigtail catheter. So assemble all the parts and make sure everything looks really, really good. And then consider carefully the position of the bladder after decompression. And so think in terms of placing your device closer to the trigone, because the bladder is going to move. I must credit my friend Jimmy Barr for this cute little animation. So let's imagine we've got a patient with an enormous bladder. We're going to come in and put in our pigtail. We're going to lock our little loop, and then, of course, everything is going to empty and drain. And so had we placed this up here, we've now got tremendous tension on that locking loop. So kind of position it for a smallish bladder. So we do go relatively close to the pelvic inlet. So this is a patient we actually did this week. I was snapping pictures like a mad thing. We've got our ultrasound in the background. We've got a huge, tense, turgid bladder. This was a dog with some horrible penile injury, and we could not at all get access to the urethra. The surgeons tried for 2 hours with catheters, couldn't get in. So the dog's got an enormous bladder. So we're just ultrasounding. This is his down leg, and this is his up leg. So do make a small skin incision just to make it a little bit easier to get the device in. And then I tell the interns, mean it. Be comfortable. Don't piddly about. I mean, be confident. So spear the bladder in a cautious and controlled fashion. You really don't need on that first advance to go in more than about 1 centimeter. So you don't nail the animal to the table, but you make a committed decision. You're going to enter the bladder and get in the bladder just about 1 centimeter. As soon as you feel like I'm in, then you take out the sharp, pointy needle. And then what you have is the hollow trocar that really can't go through the bladder. It's not going to do any damage on the far side. And then we advance the catheter and the trocar a little bit further in. So this is one of our house officers making a little skin incision. He had the wrong size gloves, which is why he looks a bit ridiculous. Making a little skin relief incision. And then he's got the device all assembled. He's kind of glancing over his shoulder to see the bladder. You can feel the bladder. He's just getting set to, with confidence, you have to hold the top end together so everything stays together. Just pop it into the bladder. We can actually see on the ultrasound image, we can see that he's gone in. You can see the metal tip very, very easily. So you know for sure that you're on target with the ultrasound. Once you're just in, you take out that sharp metal instrument. And once the sharp needle part is on the table, it's really extremely safe. And then your only mission is to make sure that you've got the catheter far enough in that all of the perforations on the locking loop are going to end up inside the bladder. So we just advance the hollow blunt trocar until we're comfortably in, and then we'll usually just slip the catheter off the end of the trocar, just as if you were putting an IV catheter in place. And if anything, we put plenty of catheter into the bladder. Once we've secured our locking loop, we can pull it back up against the bladder wall. So absolutely be sure that you're several centimeters in so that all of your holes are sitting there within the bladder. And then we remove the semi-rigid inner soft tube, and then we pull the string to lock the loop. So here we're taking out the soft tip, the blunt tipped hollow device, and the locking loop is way in here, and the blue catheter we can see sitting here. This is the little device that secures the string, and so that device is loose. The string is therefore free, so the locking loop, as soon as the central trocar is out, the device is starting to pigtail because that plastic is determined to pigtail, but it's not secured until we've secured the little string at the top. So here somebody's attached a syringe and we're starting to get the urine off while the house officer you wrap the string around the neck of the device and then you cinch it with this little blue stopper. There's various different mechanisms for how you secure that string, but basically you tighten the string and then you secure it so that it can't go back. When you want to remove the device, you simply let the string go free, and then as you pull pressure back on the catheter, the locking loop will stretch itself out and it will exit from the bladder. We routinely use a 6 French in a cat and an 8 French in the dog, and that hole will seal by itself. We usually put in a UCath just for 24 hours to get that hole to seal, but the hole will seal by itself. You have not got to go back in surgically and close it. So this is a feline patient. This was one of those nightmare, we couldn't unblock it. Let's just calm everything down and make a plan for a PU on a Monday morning. So this cat got a very enthusiastic belly wrap to keep his device in place. Usually though, if we're doing it, we put these little clear sterile dressings where the locking loop is coming out of the abdominal cavity so we can actually see the site. And then we just secure that. But this little sterile dressing lets us actually look at where that locking loop is coming out and make sure we don't see any problems there. And then attach some kind of closed sterile collection system so that we can remove the urine. Complications are not particularly substantial, but probably the biggest worry we have is ascending infection. So we treat this like any urinary catheter, so we make sure that it doesn't get contaminated, we make sure that we don't get a break in the system, so we always put on a closed collection drainage kit, and then we do put aseptic handling anywhere near where it enters the body wall, an aseptic dressing. If you were to position it inappropriately, then that would be potentially a complication. And so ultrasound guidance is very helpful because then you're 100% sure that you know exactly where you're going. Although with a patient with a large turgid bladder, it's pretty easy to figure out, even without ultrasound, exactly where you're going. And then do make sure that that locking loop is carefully secured. If it's not secured, and then somebody inadvertently puts any tension or pressure on that catheter, the catheter could be removed sooner than you wanted it to. And then leakage post-removal. So we do usually put a UCath in, maybe it's written 2 to 3 days, but often actually I'll just do 24 hours. That 8 French hole is going to close itself down very fast. 24 hours of the bladder being kept decompressed, that hole is going to seal. They seal amazingly quickly. I'll be happy to answer any questions on the locking loop. Yes? That's a great question. How long can you leave them out? Usually, I've left them in maybe for 3 or 4 days. We had a cat in recently that had a pelvic injury, and that locking loop was in for about a week. But they're well tolerated. They don't seem to cause irritation. It's more just the longer it's in there, the more risk of ascending infection, and then where are we going with this patient? But they could certainly sit in there for days. Days would not be a concern at all. Yes? I usually do just secure it to the skin with the adhesive. Some of my colleagues will put a base stitch on the skin and then do a Chinese finger trap around it. I don't usually do that because I have such faith in the locking loop. I'm more inclined to make sure that the chances of anybody tugging on it are minimized by wrapping it. So I don't bother finger trapping it, but some of my colleagues do. Yes? Are they terribly expensive? No, the locking loop catheters, I think range about $25, $30, that kind of cost. And so we have a range of them in the hospital, because once you've got a few in your practice, it's amazing how often you think, I'm going to put this thing in here. It's very, very helpful. So I think the 6 French and the 8 French probably the most useful sizes, but they go up to, the resident who was going to do that dog I took pictures of wanted to put in a 16 French. And I was like, that's like a knitting needle, and there's no need for that. But if you've got something like a pyothorax, you could certainly put in a 16 French, because that way you can get really thick exudate out. You can very easily lavage back in. But if it's urinary, my max size for urinary is 8. Urine's clear, it's going to flow easily. There's no need for a bigger diameter than that. Yes? The smallest I've seen, I think, is a 5 French, and that did not have a locking loop on it. So the smallest I know of that locks is a 6. They might come smaller than that. I'm just not aware of ones that are smaller than 6 that have a locking loop. There are catheters that have a loop, but just not a lock, and the lock becomes really important. I think, though, even in a ferret, I think a 6 French is 2 millimeters. It's a 2 millimeter tube, and so I think even a ferret, I think a 6 would be fine. Yes? There's tons. I mean, if you just do lopping loop pigtail, you'll find tons and tons of manufacturers. I think Boston make most of the ones that we use, but it's not a rare medical device anymore. So if you just Google them, you'll find them. Great. Thank you very much. I appreciate it.